All right, good morning, everyone. Welcome to Pediatric Grand Rounds. Today's speaker is Dr. Jacinda Hayes. Jacinda is a graduate of BCom School of Medicine. She completed her pediatric training here at Carilion as part of the inaugural class and a fellowship training program in Hospice and Palliative Medicine here at Carilion in 2017. Since then, she has been the director of Newborn Nursery and the NAS program. Please join me in welcoming Dr. Jacinda Hayes.
All right, good morning. How's everybody doing? Good. Excellent. Let me know if I need to adjust this at all or talk louder. It's good? Okay, awesome. I'm so excited to talk to you guys this morning about our new NAS program. I last talked about NAS a couple of years ago, and we are doing things dramatically different than a couple of years ago, and that's what I want to talk about this morning. First off, I have no financial disclosures. So I want to first talk about the history of how we manage NAS here at Carilion. I have it removed. And then I want to talk about a new way to manage these babies. And then demonstrate ways to do on how you can help manage these babies. And also learn ways and recognize ways that you can empower moms that are struggling with opioid use disorder. So I'm going to first step on my little soapbox. I always start any presentation on NAS with this. Babies are not born addicts. They're not born addicted. They go through a withdrawal process. So you'll hear a lot of times in like news or in the community, addicted babies or babies born addicted. That is not true. You have to have more mental capacity than an infant to have struggles with addiction. So these babies go through a withdrawal process. They're not addicts. So I think it's important to understand where we were and the history behind why we made the changes that we did. So that's where I'm going to start. So we used to manage these babies in an outpatient setting, and we used methadone. And at the time, it was a very novel approach. Kim Ramsey is sitting right here. She kind of helped pioneer that. If you want to wave, Kim, I want to acknowledge her work because at the time it was very revolutionary, and she presented this model of care throughout the state. Did you go outside the state?
Oh, yeah.
Okay, so very good. So we were pioneering at the time managing these babies on methadone in an outpatient setting. However, we outgrew our outpatient clinic. We were at capacity in our outpatient NAS clinic, no more slots for our clinic. And the NICU had a backlog of babies that were on methadone for NAS. And we had a waiting list to get into the clinic. And this was in 2017. So our NICU's close to being at capacity, and at that time we had 10 babies on methadone taking up beds that a preemie could utilize. And our clinic was full, and we didn't see that the number of babies was going to decrease, unfortunately, anytime soon. So we had to come together as a system and as a hospital and figure out how are we going to address this problem. And then also looking at our model of care using the Finnegan scoring system, using methadone, is this really the right thing to do for the baby? You know, we have to sometimes take a step back and analyze what we're doing. Is this really the right thing? Medicine's constantly changing. What does new research say? What are other facilities doing? And then also looking at what the moms were saying and what the families and the caregivers were saying. So not just so much what we as health professionals think, but also what do the patients think, the families. So a lot of what we heard almost daily in the nursery, in the NICU, in our NAS clinic, our outpatient NAS clinic, was the moms felt judged from day one. They felt like we were judging them before we got to know them. They didn't understand the Finnegan scoring system. How many people have seen the Finnegan scoring system? Okay. It's like 21, 23 items, it's 2 pages. Then you have to have another document to explain what those items are. It's a very subjective scoring system, and it's hard sometimes for me as a physician and the nurses to give an accurate Finnegan score, let alone having a mom try to do this at home with the baby. So there's issues there at this point. And then these babies, you know, that were born here would be on mother baby. Mom would drop them off in the nursery, because most of these moms do go outside to smoke. So mom would drop them off in the nursery. She'd come back to pick up her baby. What happened? My baby was completely calm, quiet, and now you've given my baby a score of a 15, and he's going to the NICU for methadone. So just kind of taking a step back, listening to the moms, and saying, you know what? She's right. Her baby was fine in the room, in a dark, quiet room with her, and then when she left and brought the baby into the chaotic, bright, loud nursery, yeah, that baby got a high Finnegan score and went up to the NICU to be started on methadone. Also, some other feedback from the moms was they themselves that had been on methadone said, I didn't like being on methadone. I prefer buprenorphine. The methadone made me feel terrible. I don't want my baby on that. There's a lot of education and convincing we had to do to get moms to agree to transferring babies to the NICU to be started on methadone. And then this kind of falsehood that if mom is on Subutex, which is buprenorphine, I used a brand name, I'm sorry. Buprenorphine is Subutex. Buprenorphine plus naloxone is Suboxone. So you guys have heard Subutex and Suboxone. That's what those medications are. I apologize. So buprenorphine, when that came out and the moms were being transitioned from methadone to buprenorphine, the moms are being told, oh, your baby won't have withdrawal if you're on this. And that's not true either. So we kind of took some baby steps to see if we could still maintain our outpatient NAS program. And we started implementing a pretty strict safety contract, reminding the moms it was a privilege to do outpatient treatment for NAS, that they had to follow some rules. And we started noticing our moms that we currently were serving were in a different place than historically our moms were. So our moms were sooner or just starting their recovery program. So our typical mom was changing. The dynamic of the moms and the families were changing. And this is what I'm seeing now too, is that a mom is using heroin, she finds out she's pregnant, gets into a treatment program, but she's only been in a program for like 3 months. So our moms were a little bit different than what our moms that we were serving in the past. So imagine you, or our mom, I know it's hard for some of you, imagine you're a mom and you just got into the treatment program, you're really excited about your baby, you're trying to get on the road to recovery, and your baby withdraws, has to go to NICU, and then gets discharged from the NICU, and you've got to come to our outpatient clinic once a week. We did try to help with transportation, but that's always an issue. And I'm giving you a bottle of methadone to give to your baby, and you have to do Finnegan scoring after every feed. So that's overwhelming for foster families that were used to it. It's overwhelming. It would be overwhelming for me. It would be overwhelming for any of us in here, let alone a mom that is just starting her road to recovery. So we tried to see if we increased our treatment level based on a Finnegan score, if that would cut down on the number of babies getting started on methadone, and it did help a little bit. We started trialing Eat, Sleep, Console, which I'm going to talk a lot about, and started reaching out, what are other places doing with NAS? How can we collaborate? What are other facilities doing in working with these babies and moms? And then getting education, having guest speakers come in to not only educate the providers, but also nursing staff, just doing a complete change to how we approach these families. So in December 2017, Yale University published it was a QI project that they did for NAS, and they published it, and it focused instead of on not so much on the Finnegan scoring, but 3 main issues, 3 main questions. How's the baby eating? How's the baby sleeping? How's the baby consoling? Because if you have severe opioid withdrawal in a baby, they're not going to eat well, they're not going to sleep, and they're not going to console. Yale got amazing results. And when this got published and came out, all over the country there was excitement about this. But I will tell you, completely different. It's a totally different approach to how we've managed these babies. This is the original article, and I want to give credit to them and the authors who did this work up in New England and who published their results. So everyone got excited about this new approach to treating NAS. However, it's hard to change something you have done since 1975. Okay, and you have to have a dedicated space, you have to retrain everybody, and you have to have courage to try something new, right? You have to do a total facelift and not only educate your staff and the providers, but also you have to be willing to try something new. And we were totally there. So we have to also be patient, because doing a big change like this, even though I think it happens really quickly, we have to be patient. It takes time to not only educate, but it takes time to put the proper policies and protocols, and takes meeting and planning and time to change something. And then being prepared as you can, so that when administration says, okay, you can do this, okay, let's do it, we're ready. So that's also another key. And then just getting ready, because this is a big culture change. I think it shocked a lot of our staff. So in September of 2018, we opened our, it has had several names. We're officially, as of last week, calling it the HUGS Nursery. HUGS stands for Helping Us Grow Strong, and it really embodies the model of care that we're using with these babies. So it's a dedicated space on mother-baby, low stimulation environment, so dark and quiet. And we technically have 5 beds dedicated. 5 beds dedicated to these babies. So this nursery is separate from the regular newborn nursery where it's bright and loud and we do procedures like circumcision. So it's still on mother-baby, but it's its own space. And you guys are more than welcome to come down and see it. And we also allow the moms to board, which means once the moms have been discharged, they can stay with their baby. So they get a room, and they get 3 meals, our lovely hospital food. But they get to stay and be with their baby. The babies that are at risk for having opioid withdrawal stay for at least 5 days. I'll talk later that our average length of stay is between 7 to 8 days. I'll talk about that in a little bit. But they have to stay at least 5 days for observation. That is because with the methadone or buprenorphine that the moms are on, those are long-acting medications. We're not going to see withdrawal usually until day 3, day 4, day 5, sometimes after day 5. But we're not going to see withdrawal right away. We won't see it till later. So we have to observe them for at least 5 days to make sure that they're doing well from a withdrawal perspective. Also, these babies have a lot of trouble with eating and gaining weight, so they need to stay longer. We have accepted transfers from other hospitals who have noticed that a baby is having some withdrawal signs and symptoms and maybe aren't comfortable with managing them at their facility, so they will come to us. And then we've also had babies come to us from NICU who, babies that were having respiratory issues or needed NICU care, but were at risk of having withdrawal. Once they didn't meet NICU criteria anymore, they are able to come down to us in our NAS nursery, our HUGS nursery, our HUGS nursery. So actually we've actually had 122 babies in our HUGS nursery since opening, but I've only analyzed data on 115. So that's what we're going to go with. So what makes our program unique is that we're trying to meet with moms to do some prenatal education on NAS before they deliver. A couple years ago, the typical scenario was mom would be in a treatment program for opioid use disorder. She would come, deliver her baby, and then she would meet a provider in the nursery. You know, sometimes we don't see them after they deliver. It might be the next day. And that's when we are telling her, hey, your baby could withdraw. This is what it looks like. You have to stay for 5 days. This is how you can help. And if she has not been told that, that is very overwhelming. And it didn't go over very well. So we're trying to help with that process by doing prenatal education. I have to give huge props to our OBOT program. OBOT is office-based OUD treatment. Did I say that right? Office-based opioid treatment. Dr. Kim Simcox has opened one dedicated just to pregnant moms. She opened it in February. But before that, the psychiatry department has also had a lot of pregnant moms in their OBOT program. And part of that, their programs are educating pregnant moms on NAS and how the moms can help after baby is born before she even gets to the hospital. So that's huge. This is part of that culture change. We have to make a judgment-free zone. And that takes time. And that takes learning more about addiction and kind of learning what these moms' typical day looks like. And we have to check the judgment at the door because they can sense that. And we want to meet them where they're at and provide the best care possible. So we have to create a judgment-free space when we're working with these families. And then right after delivery, we're starting all the non-pharmacological environmental things we can do to prevent withdrawal or lessen the severity of withdrawal. And then just knowing what opioid withdrawal looks like in a baby and what are things we can do to prevent those signs and symptoms that we know are going to happen. So it's just kind of using common sense, back to basics. It's kind of more of a high touch and less medication approach. So in some of these, you're going to be like, what, that really works? And I'm going to show you, yes, it really works. So I've already mentioned having a low stimulation environment, so quiet, dark setting. This happens in the mom's room, not just in the HUGS nursery. It happens in the mom's room. So keep your TV low. How many times do we walk into a room and the TV is blaring? So just telling them, just keep your TV down, keep it kind of dark and quiet, limiting visitors. So after a baby's born, everybody and their brother wants to come and see the baby. So we try to tell these moms before they deliver, why don't you encourage your family to only come a couple at a time, or maybe even wait to see the baby till you get home. So we're trying to help with that. Kangaroo care is skin to skin, baby on mom's chest. So we really promote that. We actually do that for all moms after they deliver. We do kangaroo care the first 2 hours after delivery, but continuing that while mom and baby are here in the hospital. And then keeping them swaddled. Pacifier. We love pacifiers for NAS. And even if mom is breastfeeding, the pacifier really helps them learn how to suck and coordinate so they can breastfeed or bottle feed. Also, I have a prop here. Hopefully it doesn't mess up most of my microphone. So holding them is in a certain position. So you want to hold them in a C shape and kind of flex. Light is right in my eyes. So hand on the head, hand on the butt, leg flex, right on your chest. So what does this look like? The womb, yes, looks like the womb. So they love this. They have to have boundaries, right? Hand on the head, hand on the butt. They're flexed, make this nice C shape, and their head's right on mom's chest where they can hear her heartbeat, okay? If mom is not available, anyone else can do this too. Does that make sense? Yes.
About blocking the airway, because we teach in the education part of it to always make sure that their head is kind of in that neutral position to keep that airway open. You're pushing the head forward, is that not a concern?
My doll is not a perfect baby model. I am sorry. We do not block airways.
I know, yes, I know that, but, yeah, I think she's right. Her doll just isn't the perfect.
Okay.
You can keep the baby's neck in midline and still have some support.
Great question.
Yeah.
Any other questions so far? This can totally be interactive.
Wait a sec.
Gentle rocking. So not so much the rocking of like we think of we're rocking, holding back and forth in a rocking chair. It's also side to side, like the womb, and up and down, like the womb. Okay? So we can do that. And then using a baby swing, a therapeutic swing. You can use any kind you want. We don't endorse a specific brand. But limiting that to about 10 minutes, because you don't want to just keep the baby in the swing, right? That was a perfect question, because now we can talk about that. You don't want the moms to learn that, hey, I'm just going to keep my baby in the swing for hours and hours, because that's not safe either. Recovering their hands, all babies are born with really long nails, right, for full term. And so almost all babies will scratch their face. But the NAS babies definitely, I should say babies at risk for NAS, definitely will get very irritable and will scratch. So we cover their hands. Mittens, socks, our little shirts in the nursery actually have hand covers so that we can prevent that. Because I have seen where they scratch so badly, it gets infected and just really red, and it then causes them pain. So these are just simple things, right? But they make a big difference. And then we know these babies are going to have diarrhea. That's part of withdrawing from opioids. And we know that they're going to get really bad excoriation and breakdown of their diaper area. We know that's going to happen. So we put a barrier film skin protectant on their bottom to help prevent that. And we've actually seen some really good results with that. So again, just trying to think about what we know is going to happen and how can we prevent it. Okay, we also cluster care. So there's no designated care time, like in a NICU setting, the care time, no one touches the baby until it's the care time. No, we don't do that with these babies. And we also try to anticipate their needs. Okay, so it's been 2.5, 3 hours. They're probably going to wake up and want to eat. Let's start getting ready for that. Let's start prepping for that. Because when these babies wake up, and if they get very irritable and start screaming, it's really hard to calm them down. So we want to try to anticipate their care needs. Also, I don't examine a baby if the baby is sleeping. We have to wait until the baby is awake. We don't go and disturb these babies. We let them sleep. Okay. Music. So, music is amazing, right? Very therapeutic for all ages, but especially for these babies. But it's not rock and roll music. It's not country music. It's lullaby music. And we want to limit the music unless it's mom. Mom's voice is baby's favorite voice. Okay. So if mom can sing and hum as much as she wants. But if we're actually playing lullaby music, we're trying to keep it to about 10 minutes, just so the baby doesn't attenuate and have to always have that music, but just to kind of help them calm down. Mom's voice is the favorite. Female voice is the second. Dad's voice is the third. Sorry to any dads out there. It's just a pitch. the pitch of the voice is what is most comforting to them. I cannot sing, not at all. I'm a terrible singer, but anybody can hum. And I learned this from Dr. Dawn Forbes. She's at University of Kentucky, and she is an NAS expert, because that's all she does. And she said, anybody can hum. If you don't think you're a good singer, you can hum Twinkle, Twinkle, Little Star. And I want to show you guys something that I have learned from her, is if you've got a really upset baby and you're trying to calm them down, but you need to set them down, you can hum and kind of gently rock. Try to lay down in the bed. If the baby starts stirring, gently come back up. Keep humming and singing. Do that for a little bit. Try again. So, does that make sense? I think that would work for any baby, by the way, but especially for these babies. So we just talked about all these great environmental non-pharm interventions that we can do. The most important part for these babies is mom being involved. Baby only knows mom. We, even though we should not judge, we might think that she's not a great mom. That baby doesn't know. That baby doesn't know anything differently. They know her voice, her heartbeat, her scent. So to baby, mom is number one. And I will show you when I go through our data that we see this anecdotally, but I've also got the data to show it. So mom is number one. And when we tell these moms now that they make such a big difference, it just empowers them, and they want to stay and take care of their baby. And they want to continue in their treatment program so that they can be a good mom. We do encourage breastfeeding, unless, of course, mom is using heroin, cocaine, or methamphetamine. That's across the board. And then, of course, HIV positive. I'm just going to go ahead and say it because I always get asked this. A lot of these moms do have hepatitis C. You can breastfeed if you're hep C positive. Unless you start getting cracked, bleeding nipples, then we advise that you halt for a little bit. But a lot of times people think hep C is a contraindication. It's not. So also, moms being on buprenorphine or methadone, we definitely want them to breastfeed. A little bit of those medications go through the breast milk. It's a very small amount, and it actually kind of helps treat the baby a little bit. So we do encourage breastfeeding. If mom cannot breastfeed, or if mom is not available, we are currently using an extensively hydrolyzed formula that has no lactose or sucrose, has a probiotic, and has the most protein per gram. Because these babies do have issues with growth and weight. So that's currently what we're using. No sucrose and lactose are important because the sucrose tends to make the baby's diarrhea worse, and then their GI tract is already so inflamed from the withdrawal process. We're just trying not to use lactose. We start off with 24 calories. Again, we know they're going to lose weight and have trouble with growth. So we're starting off with 24 calories. If even adding nutrient powder to mom's breast milk once her supply is established. So we're starting off with 24 calories. We know they're going to lose weight. Let's see if we can help by starting off with higher calorie concentration. Once their weight loss is over 8%, we'll go up to 27 calories. If they start having worsening diarrhea, we can back that back down. But I've seen a lot of these babies tolerate that and actually will start growing on 27 calories. I'll also remind you they already have diarrhea. So I'm looking for if the diarrhea is worsening with the higher calorie concentration. This doesn't mean they have to be on this long term. I'll usually, if they're using WIC, I'll fill out a WIC form for 1 month, so that at that 1 month check, their PCP can kind of analyze, okay, do we still need this formula? Do we still need these calories? Of course, this is individualized. Okay, so I do want to just tell a little story. So we want them on higher calories, right? And we go over with the moms how to mix the formula. That's huge, right? Peds for NICU, nursery, how does mom properly mix the formula? We go over that with them. I realized that on our mixing instructions that it says TSP, teaspoon. There's abbreviation, CU is cup. I realized when a mom asked me, what do those mean, that they had no idea. That TSP is teaspoon, CU is cup, TBS, tablespoon, all that. And that they did not have those instruments at home. So we had somebody donate cups, tablespoons, teaspoons that we give to the moms to take home with them so that they have the proper equipment they need to properly mix the formula. So just little things you learn as you go along. Things that we take for granted, right? I mean, I hope, well, I don't want to make assumptions. But I have those measuring devices in my house, and I know what that abbreviation means, but not everybody does. Consults, we have speech therapy. If a baby is bottle feeding, come in and make sure that they don't need a special bottle or a special nipple. PT, I see Melinda. PT and OT will also see all of these babies. They all qualify for early intervention because of their in utero exposure. And then PT and OT will also teach the moms just some exercises. I don't want to.
Just kind of going over what you've already said with the rocking, holding, soothing,
so reinforcing
that we take for granted.
Repetition is key, right? So the more times they hear it, the better. But just teaching her things, teaching mom or the caregiver things that they can do to help in the long run with baby's tone. Because a lot of these babies have issues with hypertonia. So we want our therapies involved. Child life and then social work. Our social workers see all of these babies. Virginia state law requires that all of these babies, even if mom is in a treatment program, get a referral to CPS. CPS may screen it out. CPS may just do a safety plan saying, good job, mom, continue in your treatment program, keep up the good work. They may do a removal if mom is still actively using heroin or methamphetamine. Yes.
Another question. So I'm a community person, that's educator.
Yes.
So I was recently doing some education with foster families, and they had gotten, not an NAS baby that I'm aware of, but a preemie baby. And I said, well, what type of education did you get when you see the baby from the hospital? They're like, none, zero. And I said, I know our educators and parent educators on the NICU do an awesome job of parent education before the babies go home. Do you have a plan for that, or is that happening? Or
for our NAS patients?
For foster families.
So I have to tell you that after the baby leaves, most of the babies go home with their moms. This is a downside to not having the outpatient clinic. I we no longer see those babies. I do not know if later they end up with a foster family. My pediatric floor hospitalist colleagues might be able to weigh in on that. But
we did have a foster family room in board in the NICU, and we taught them how to take care of the baby. That was kind of an isolated case. I don't remember the specifics of it, but I remember it happening. So I guess you and I can talk later about, like, what specifically did they not know how to do? Did they not know how to change a diaper, give a bath, like what?
I can tell you that if mom is actively using heroin at time of delivery, CPS will most likely do a removal, and they'll try to find a family member, so a grandparent, or another family member, aunt, that can come in and take care of the baby. And we let those family members board and stay with the baby on mother babies. So they would then get education while they're there. We are constantly educating this for our NAS families. It's that while they're here, it's like 24/7 education from nurses, providers, therapy. So I don't know if I answered your question. I'm sorry. Okay. How are we assessing these babies now? No more Finnegan. Whoop, whoop. Everyone is happy. Nobody likes it. So very good. We are asking 3 questions now. Inspired by Yale's Eat, Sleep, Console. So we've come up with our own thing because we're doing things a little bit differently. One is coordination. Is baby able to eat and coordinate feed? 2 is comfort. Can they rest comfortably or sleep or rest? Just are they comfortable? And then calm. Can we calm them down within 5 minutes if they get fussy? Are we able to use our non-pharm interventions to calm them? So 3 C's for Carilion. And we had to do this because we're not exactly following Yale's Eat, Sleep, Console model, but they greatly inspired us, and I have to give them huge props for their work. If the baby is not meeting those 3 C's, we can do a PRN dose of morphine, 0.05 mg/kg. And we give it in the HUGS nursery, and they're on a pulse ox machine for 2 hours after the dose is given. If no improvement after that dose, you can try a larger dose, up to 0.1 mg/kg. And then if that seems to help, we can repeat that dose every 3 hours. If they're not responding to the morphine or they are regularly needing morphine, they will go to the NICU. So if they're getting it every 3 hours, they need to be upstairs where they can be on a true monitor, not just a pulse ox machine. Or if we've given the dose and it made no difference, we gave the 0.1 mg/kg dose and it didn't touch any of the symptoms. And then, for the babies that go up to the NICU, once they're on an established, scheduled morphine dose, they will then come back down to us. Instead of remaining in the NICU, they'll come back down to our HUGS nursery where we can wean the morphine a lot more rapidly than we could with the methadone. So methadone is gone. We don't use it anymore. And we're using morphine. So does this really work? Yes, it does. I don't have time, but I could tell you story after story after story after story. But I want to spend time going through the data that we have. So of the 115 babies, we've only had to transfer 4 to the NICU. That's 3% that had to go to the NICU for scheduled morphine. Then, once they were captured on a regular standard morphine dose, doing well, they then came back down to us instead of staying in the NICU. All 4 of these babies were exposed to heroin, and mom was not available to provide care for them. So either she wasn't in a good place, or it was a removal. So all 4 of these, heroin exposure, mom not there in the nursery to help take care of the baby. 24 of the 115 minus 4, 24 of the babies received 1 to 3 doses of morphine, and that's all they needed. And what we're seeing is kind of at that peak of withdrawals, like day 3, day 4, day 5, it varies by baby. They get 1 or 2 doses of morphine, gets them over the hump, they're fine. Withdrawal is a temporary process, so if we can get them through it, they do very well. So these babies did not go to the NICU. They stayed on mother baby with their mom. Because when we give morphine, they're in the HUGS nursery on a pulse ox machine, and we want baby on mom's chest, mom holding, rocking, doing kangaroo care, mom there to kind of augment the morphine that we're giving. So I wanted to just quickly look at the mom demographic. Most of them are on MAT, which is medication-assisted therapy for opioid use disorder. So they're in a treatment program. That's awesome. Most of them are on buprenorphine. Sorry. 13 of those babies' mom was using heroin at time of delivery. So if you remember, I said 4 babies went up to the NICU. So even these non-pharmacological interventions work for heroin exposure. But obviously, if mom's in the treatment program, the babies and moms do better. Oral opioids, some are prescribed, some are not. A lot of our moms are early in their treatment program, so less than 6 months, less than a year in their treatment program. So this tells us the type of mom we are working with and trying to partner with so that we can be more effective. So most of them are early in their addiction treatment, which is what we were seeing. But when we go back and analyze the data, that's really what we're seeing. Gestation, so a lot of times with opioid exposure, babies are born, a lot of times can be born prematurely. But since a lot of our moms are in a treatment program, they're making it longer in their pregnancy. Historically, NAS is associated with SDA, but a lot of our moms are in a treatment program. So a lot of our babies are actually good size. This is where it also tells us more about our moms. A lot of our moms have also, instead of opioid use disorder, have a mental health diagnosis, and they're on medications for that, whether it's bipolar disorder, depression, anxiety. As you get to talk to them and you get to know them, and they start sharing information with you, a lot of them have past traumatic experiences, either as children or teenager or even as adults. So those adverse childhood experiences that we hear a lot about, it has impacted our moms. Domestic violence, other types of abuse, PTSD. So as you get to know them, you kind of understand their history and their journey. I was actually shocked that only 70% for tobacco, because I feel like they all smoke. But 70% tobacco. And then for first baby, it's actually only, when I went back, it was actually only 15%, which kind of shocked me because I felt like a lot of the moms, they were new moms. And then I started realizing that this is their first baby that they're getting to be a mom for, and they're getting to keep, and because they're in a treatment program. So they're now able to take care and be an active participant and be a mom. And then dads, I love when dads are involved. I think dads are very important. But a lot of our moms are single parents, and they're the sole caregiver. A lot of our moms don't have a lot of support. So our average length of stay has been 8 days. If you take out those 4 babies that needed to go to the NICU for scheduled morphine, our average length of stay is 7 days. So I mentioned earlier we observe them for 5 days. A lot of times they need to stay 1 or 2 days extra to work on gaining weight. And this I'm so excited about. So 46%, almost half, are getting breast milk when they're discharged. I will tell you that usually it is pumped breast milk, but that is okay. And this is actually pretty equivalent to all of our babies that get discharged from our hospital. So I'm really proud of our moms putting in the work and pumping and giving breast milk. And because they're staying for 5 days and we're allowing them to room in and board, they have lactation support, they have nursing support. So on day 3, when their milk starts coming in, they're like, oh, I can breastfeed. So, and they can just go right down the hall. Lactation will help them, and our nursing staff helps them with breastfeeding and pumping, whereas they might not have that opportunity if they were at home. So this is kind of a breakdown of where our families live. Obviously, a lot of them are the Roanoke area. The second largest is Franklin County, and then you can kind of see the breakdown. But we've had babies from North Carolina, West Virginia, Danville, Allegheny. By the way, all this information is on my poster. If you want to up close, more intimate look at it. So this is just a graph showing the exposure. As I said, only 13 babies were heroin exposure. Most is moms are in a treatment program. But very early in their treatment program. I talked about this. So I'm going to keep going. This is what I want to talk about too. So readmissions. So does this work? Are they coming back? We've had 7 come back. 5 for failure to thrive, needing to work on weight and eating. And then 2 coming back and needed morphine. One of those did have to go to the NICU for scheduled morphine. He had withdrawal around 7 days. Mom was on methadone, and sometimes with methadone exposure, you don't see withdrawal till later. So we have had 2 babies come back and need medication. So 2 biggest surprises that I would have never thought when we first started are new approach to NAS is that, one, the moms are staying and rooming in with their babies. And shame on us for thinking badly, but we were anticipating that when the moms got discharged and the baby had to stay, that they would leave. And but that has not been the case. 88% of our moms stay and room in with their baby. And then they're providing breast milk. I am really shocked at that too. But again, I should have had more faith in them. So what are our goals? Prevent withdrawal or lessen the severity of withdrawal with all of the non-pharm interventions we can. And then to get mom and baby off to a good and healthy start, obviously. Oh. I was supposed to do questions. I have time. Okay. These are easy. So, babies are born addicted, true or false? Excellent. If mom is on methadone or buprenorphine, she cannot breastfeed. Are these questions a new thing that we have to do?
Yeah.
Okay. Does this qualify? Okay, I think I need to stop. Yes, please.
What happens to the babies after they leave the nursery?
They see their PCP usually within 1 to 2 days.
And is there any follow-up?
No, I wish. Oh yeah. Oh yeah. Yeah. I wish that we could follow them. Like,
You want to follow them?
yes. Yes. Oh, so many questions. Okay.
Being transferred to the NICU, what measures are being taken to incorporate the non-pharmacologic interventions in the NICU?
I have done education with the NICU staff on ways that they can utilize these upstairs in the NICU. Obviously, the environment's a little bit different, and that's why a lot of places are looking at getting these babies out of the NICU because it is an overstimulating environment. But I think the NICU nurses are doing a really good job. I don't know if you want to weigh in. Okay. Or if Dr. Patel wants to weigh in. But they have had education on ways that they can try to do this upstairs.
Is there talk about eventually trying to get that out of the NICU and being able to, if you're starting them working down in your HUGS nursery, would you be at a place where you could get them on a schedule to stay
Instead of going to the
without having to go to the
NICU?
NICU?
I think because of how our nursery is, the certification, the state, what am I trying to say?
Yeah.
The state regulation, I don't know, can we have cardiorespiratory monitors in our nursery? Does anybody know?
I don't know. I think we've looked at that, and that's why we're doing what we're doing now.
Yeah, I feel like the type of level nursery we have, we can't.
Yeah.
But you bring up a good question. I want to answer everyone's questions, but I do want to say our program is new, and we are open to making it even better. Like, it's got a great foundation, but we want to make it even better.
You have the nursery itself, but the moms room in. What strikes me is all the education, the way you treat these babies. So just so I can get a visual image, how much time does the baby spend in the nursery, and how much time does the baby move with the mom?
So a lot of the babies are in the room with mom most of the time. If mom goes out to smoke, she drops the baby off. If mom has to go and tend to her older children for a couple hours, or if she has to go to her treatment program to get her medication. But the babies are in the room with mom most of the time.
Educating them to do all the...
Yeah, they're stepping up. They're awesome. Yeah. Yeah, because the baby gives them motivation to not only continue in their treatment program, but the baby empowers them to be the best mom possible. It's really cool. Yes.
Instead of get started on gabapentin or quantity.
Oh, I can talk about that, yeah.
Is it safe in the outpatient setting? When do we wean at all?
Oh, it's very safe in the outpatient setting, because when we did methadone outpatient, we do gabapentin and clonidine. That is not the norm. That is severe withdrawal when I use clonidine, or if mom is on gabapentin and is not available. The great thing about the Eat, Sleep, Console model and our 3 Cs model, focusing on the non-pharm, is it helps with SSRI exposure, gabapentin exposure, opioid exposure. It helps with any type of medication that a baby could withdraw from. Tobacco, which is actually a toxicity.
One more question.
Yes.
So out of your 115 patients, out of like the 8 days, what was the average total dose of morphine that they received?
Oh, most babies only get 1 dose.
Okay, just the 1 dose?
Yes.
So if they had to be transferred to the NICU, is there research or are you looking into like using something like Precedex or pain and sedation over morphine since the...
That's a great question. I've not looked at Precedex, but I have, for a couple of babies, started clonidine to try to keep them from going upstairs to the NICU.
Okay.
Clonidine is amazing, by the way, for NAS.
Let's come first at the last question, please.
The answer that you guys give on how to use the formula is one of the most complicated things I've ever seen. I'm glad you guys are giving them the cups and the tea, so that helps. But I think there's an easier way to get them to mix the formula because they're still not mixing it accurately, which I think leads to the failure to drive the outpatient setting.
I totally agree with you. So what I've started doing is just writing it right on the can and trying to make it simple, like 2 cups in 2 ounces. Or I just made that up. I don't know that. But trying to make it simple. I agree that sheet, I'm not using it as much anymore, and I'm putting a sticker right on the can and writing it on the can. After, I don't know how else to.
I think there's other formulas out there. Formula, not formula. Like the Mayo Clinic uses it like a different mixture to get to that point. Description. Yeah.
Okay. Well, recipe. Yeah. Okay. Yeah. But please let me know if you have other ideas for us. Thank you.
Thank you.